just want to start by saying thank you to some of the mentors who have helped me out with the case. Dr. Smith, Dr. Singh, who's here, Dr. Lowe, and Dr. Southard. I don't have any relevant financial relationships. I'd love one if anybody wants to find someone for me. We'll start with an 87-year-old lady who had a prior history of an aortic valve replacement in 2011. She had a single vessel bypass at that time as well. She had done great after surgery. She was previously NYHA Class 1, but she's been having a lot more fatigue and progressive limiting symptoms. She's now more like NYHA Class 2, maybe probably 3. And so she got a repeat echocardiogram, and she was having worsening stenosis of her prosthetic valve and also a fair amount of insufficiency. Just to kind of flesh out the history a little bit more, the bypass that was done was for an anomalous circumflex artery. It rises from the right coronary cusp, and it was pretty diseased in its anomalous course. And so they had dropped a saphenous vein graft to that, and they had replaced her aortic valve at the same time with a 21-millimeter mitral flow bioprosthetic. She's also got hypertension and dyslipidemia and osteoporosis. She's a little thing. She's about 5 foot nothing and 140 pounds. Just a quick look at her echo, and the peristaltic long axis isn't the best view. The apical 5 is a little bit better to show you that she's got a lot of aliasing coming through the valve and a fair amount of AI there as well. And her Doppler flow characteristics from that apical 5 chamber, so she's got a Vmax of about 4.5 meters per second and a mean gradient of 53. Her valve area, if I remember, it was like 0.6. So, she'd been evaluated by surgeons, and, they weren't really excited about an 87-year-old, 5 foot nothing, 140-pound lady with osteoporosis going for a redo. She was intermediate risk. Her STS was about 6%. And so she was seen in the transcatheter valve clinic. And we started doing all of our workup, and at this point I was reading a lot of CTs, and the CT was kind of concerning because her right coronary ostium is a little bit low. The mitral flow valve is about 13 millimeters high, and so we're really concerned, naturally, that she's going to have RCA osteocclusion when we put a bioprosthetic or a TAVR valve in there and stand her bioprosthetic leaflet straight up. But when we look at the CT images a little bit closer, the potential solution might also be there. And that anomalous coronary circumflex comes off essentially with common ostium of the right coronary cusp. Now, it's very small and diseased and it's been bypassed. And you can see the bypass graft looks pretty patent on the CT scan as well, and it hooks up that circumflex and takes that posterior course instead of anterior in between the PA or the RVOT and the aorta there. And here's a 3T reconstruction we're able to do. And if I kind of lay it down on its side, you can see there's the graft and there's the anomalous circumflex and that nice, quote-unquote, safe posterior course. So we decide that we'll engage the anomalous origin of the circumflex, and we'll do PCI through that disease portion. And then that saphenous vein graft that's hooked into the circumflex will provide some collateral flow back to the RCA ostium. Then when we put the transcatheter valve in, if the ostium is occluded or closed off from the native flow, we've got bypass flow going into the right coronary sinus through that circumflex that's anomalous. We're going to do PCI and TAVR all at the same time femoral approach. It was planned for general anesthesia for her TAVR as well. And then we'll put in a 23-millimeter evolute R valve, a little bit superannular, try and minimize our gradient. She does have the mitral flow valve, and so the internal diameter is only 17. And so we think we can sneak a 23-millimeter evolute R in there. So this is the initial shot, and you can see the severe disease portion there in that circumflex right next to the RCA. We have a 7 French MPA guide catheter. We're able to get across with an FC, use a fine cross to kind of support a little bit, and then exchange out for a choice extra support. We do some hammering with a 2.515 semi-compliant balloon, and we get an angiogram that looks like this. And some of you notice that our wire position probably isn't optimal, so we moved it. We put a BMW there instead, and it goes, as you can see, out the vein graft. So we've got a really nice rail now. Then we start putting in stents. We'd use 2 Xience everolimus eluting stents, a 2538 distally and then a 2533 proximally. And after some more hammering with a 275 NC balloon, we have something that looks like this, and you can see some nice competitive flow in the saphenous vein graft. And the 2 ostia are right next to each other. So we're pretty happy with this result. Just another view of it. And we injected the saphenous vein graft, and you can see that there's flow that goes through that portion that we just did PCI on, and it fills, at least partially, with competitive flow. the right coronary as well. So we're pretty happy with the way things are going, and we get ready to do the TAVR. Here's some just TE images, a short axis view of the valve with some 3D reconstruction. And then here's all that aliasing that we saw earlier with our aortic insufficiency as well. And the valve actually went really smooth. We did not do a pre-BAV. We were able to kind of just lay it in there real nicely. We did sort of recapture, reposition once, and then let it go, and we were really happy with the way it looked once we released it right there. The TE immediately afterwards shows there's essentially no leak at all, and we're really happy about that. Here's a nice 3D reconstruction from the TE, and you can see it's a little bit superannular there. And our gradient afterwards by echo is really nice. We like that we have only an 11 millimeter gradient residual after placing the 23 millimeter valve. Do a quick root shot, and you can see filling of the left coronary and maybe some slight filling of the right as well. And there's our valve with no leak. And then we do a quick repeat angiogram of that saphenous vein graft, and if you wait long enough, you can see that there's competitive flow down the RCA from our quote-unquote anomalous bypass. And so we're really, really excited. We think she's well protected, and she did well. So just an interesting and creative, novel way of trying to protect a low coronary height, which, you know, some patients with this might not have gotten a TAVR and might have been sort of, you know, cohort C, if you will. You know, we were lucky that she had gotten that bypass graft when she had a previous aortic valve, because now we had a conduit for kind of protecting her right. Thank you.
I think overall, this is a very unique case and a very innovative solution. You're looking at it both from a coronary standpoint, an ischemia standpoint, and also a valve standpoint. I guess one of the questions I had is, if you ended up opening all this pathway from the SVG all the way down to the right, how would you know, or were you just thinking it's going to be okay in terms of any ischemia down the OM because of steel going down that massive way? How could you, was there any way you could have predicted that, or what would you have done if that happened?
I don't know if we had a good backup plan for that when we were doing it. It certainly is a big right, and I think the picture at the very end is kind of reassuring to us, especially that it looks like there's competitive flow. So there probably is native flow down the right as well. It's not completely sealed off. But we didn't really have a big contingency for what we're going to do about that OM at the time.
Yeah, that's very interesting. Yeah. Any comments from the audience?
All right. That's a great case. Thanks, everybody.